bariatric surgery, and I live in the northwest of Spain. As you can see, Spain has been one of the most affected countries in the outbreak of coronavirus. And this Friday, we had 230,000 cases and 27,000 deaths in our country. In early March, waves of coronavirus patients were being admitted into emergency care, and a huge number of intensive care beds were needed. So we were forced to stop elective surgery for a while. The incidence of COVID-19 were different in the Spanish regions. We have the highest incidence in the center and less incidence in the northwest where I live. But in spite of that, we show really difference between the surgeries that we were performing before the outbreak and after the outbreak. For example, you can see here that in January, we performed in my service of general surgery 559 surgeries, and in April, we performed only 154. Regarding the MIS, we didn't really stop performing MIS. We reduced significantly the number of surgeries. As you can see, the highest reduction was in the second part of March. So we practically stopped. We only perform oncological and emergency cases since then to 20th of April. But we performed the minimally invasive surgery, the same indications as before. And from last April to now, till now, we are performing also priority benign diseases. So how surgeons face the COVID outbreak in Spain? We gather a focus group, a crisis committee within the Spanish Association of Surgeons with the leadership of Salvador Morales. We search for evidence, we connect with surgeons in Italy, in China, and also in the highest incidence areas in Spain, Madrid, Barcelona. And we publish some recommendations, some documents of recommendations regarding how to operate COVID positive patients, the recommendation for oncological patients, and the recommendations for restarting the surgery in the next phases. So this is, following these recommendations, this is our diagram in my hospital in Vigo. So we try to schedule surgery 15 days before. So we have time for performing a questionnaire for clinical and epidemiological screening. And then 74 hours before surgery, we perform a PCR test. We repeat the questionnaire 24 hours before the surgery. And if everything is negative, then we proceed with the surgery. If some of this is positive, we delay the surgery, we send the patient to the COVID team and to the multidisciplinary committee. We divide the hospital.
Sorry to disturb you. I think a lot of attendees are not able to see the screen. If you can stop your screen sharing and restart it, can you try it one, please?
Okay. So you can see the screen now?
I was able to see earlier, but I got a lot of messages saying, can Dr. Khalid mention if he can see the screen now, or Dr. Khalid?
See the screen.
Yes,
so,
now
we can see it, yes.
Yeah?
Yeah.
So,
no, I think not seen by the attendees. So somehow there is a...
I think it is visible to all panelists, not the delegate.
So can I continue?
I think the attendees are not able to see your screen. That is a message.
So okay, maybe I can explain with words.
Yes,
they can hear me?
Absolutely, they can hear you.
Okay, so I explain with words.
Yes.
We divide the hospital in two parts. One is COVID-free. So we have in this COVID-free area hospitalization wards, operating rooms, and intensive care. In this area, we are really strict with the recommendations and the rules. Visitors are limited. Everybody is wearing a mask. We insist on washing hands, and we perform daily clinical screening for COVID. And when a case pops up, then we rapidly send the patient to the COVID area. We insist on enhanced recovery programs to minimize the hospital stay. So why do perform the preoperative screening? We know that when the patient is COVID positive and we perform the surgery, there are more postoperative complications and the mortality can be 9 times higher. So we have to avoid to operate a patient that is infected. Also, we know that 30% of infected patients are asymptomatic and 50% only have mild symptoms. So it's important to make the clinical and epidemiological screening 2 times before surgery, 14 days before and 48 hours before, and we perform the test. So our current policy for minimally invasive surgery is basically that nothing changed. It's true that we are performing really few surgeries, but our indications are the same. We know that the RNA of the virus has been detected in stool, blood, and even in peritoneal fluid, but we also know that they couldn't grow this virus in the cultures, so it has not been proven the capacity of this RNA to be contagious. We also know that the smoke, the surgical smoke, has been a hazard with other viruses like papillomavirus. Maybe it's the same with coronavirus, but this surgical smoke is the same in open and laparoscopy. So even with the minimally invasive surgery, you can control the smoke and you can evacuate whenever you want. It's not the same in the open surgery. There is also a concern about the aerosol produced by the laparoscopy, but I think that with the open surgery, you have also the possibility of having more smokes, especially if you are using some harmonic or high energy devices. So we think our crisis committee that there is not enough evidence to not recommend minimally invasive surgery during the COVID pandemic. But there are some precautions to be taken. I think it's really important to have a COVID-free area in the hospital with operating rooms, hospitalization ward, intensive care. It's important to perform preoperative screening for COVID, clinical, epidemiological features, and also tests. If you don't have the test, then you can use a CT scan, thoracic CT scan. It's important to minimize gas leaks and to use smoke filters. We use water seal to connect these smoke filters to avoid that the smoke could go to the air of the operating room. The team is using FFP2 mask and protective glasses and screen. And if you are not sure of the COVID status of the patient, then it's better to use a full PPI. SEIS and AIS recommendations are really similar to those of the Spanish Society of Surgeons. They also think that there is little evidence of MIS risks specific to COVID-19. And there are the proven benefits of reduced length of stay and fewer complications with the minimally invasive surgery. So this is the same during the pandemic and before. And they recommend also the use of filters, minimize use of energy devices, minimum number of theater staff, all patients tested prior surgery if possible, dedicate an OR for COVID and also another one for non-COVID patients. And I think that you can perform minimally invasive surgery safely in these times with all of these precautions. Thank you very much, Dr. Bindal and the Clinical Robotic Surgery Association for inviting in India, for inviting me to participate in this webinar. I'm really sorry if you were not able to see my screen. I don't really understand what is the technical problem, but I hope that my explanation was enough to understand what are we doing in Spain. Sorry for the
inconvenience. It was a very
inconvenience.
lucidly presented talk, Dr. Santos, and most of people are able to see the screen. There was an issue with just few of attendees because many attendees have messaged me that they are getting the screen. So I think the message was loud and clear, and it was, some attendees have a previous version of Zoom. I think that is the problem. So you have to update your Zoom versions to be able to see the screen. So, so you have been starting minimal access surgery, you are now doing it, and I think it's very reassuring to hear from Spain, which is one of the worst hit countries, that you are doing MIS and you're not that much concerned about various things which have stopped people doing the surgeries. So what I'll do is I'll launch maybe the second poll, and then every attendee can answer this question, and then we move to the next presentation from next country. So do you perform a COVID test before all general surgical procedures? First option is COVID testing done before all procedures. Second option is testing done before all procedures except emergency. Third option is COVID testing done only in suspected cases of COVID-19. And fourth option is testing not done or not available in our place. So if everyone can answer this question, we'll have a fair idea about the testing protocols of the attendees today.
So we at Cleveland Clinic Abu Dhabi, we test all the patients before surgery, 100% of the patients.
Wonderful. Yeah. So that would be the first option. And I think that's kind of coming out as the first one. So I'll end the poll now. Here are the results. So 52% say that they test before all surgical procedures, and 26% accept emergencies. So, it's 78% are doing it in all procedures except emergencies, and only 7% are not doing it. So, okay, this was another poll. We'll have the third poll afterwards. So can I request Dr. Daniel Guerron from Duke University to kindly present his experience and their protocols about COVID-19 in their area. Dan is a very good friend.
Sure.
Director
Thank
of
you. Can you see me?
at Duke University.
Can you see my slides? Can you hear me well?
We can hear you, but we can't see your slides. Have you shared the screen?
I have. Let me
Can
just
you share
double
it
check
again?
now. How about now?
Yes, now we can see it.
Okay. So thank you. Good morning, good afternoon, good evening. I want to thank Dr. Bindal and the CRSA India for the kind invitation and the opportunity to present today. I want to say hi to all my co-panelists and thank you again for all the people listening. I'm going to present a little bit of the experience that happened in my state and the global perspective in the US. Thankfully, in my state in North Carolina, we've had a relatively mild impact from this pandemic. My disclosures are there, but I want to say that the details and the dates that I'm going to present here change quickly and often, and have been changing so rapidly that at some point, we don't know what is going to be next because of this pandemic characteristic of moving quickly. This is the latest report from my state. As you can see, we had almost 250,000 completed tests with 752 deaths. And currently we have 481 patients hospitalized in about 90 counties all over the state. In my hospital currently, we have 41 patients in the hospital, and I am treating or the general surgery service is treating currently 2 patients. One of those is mine that I'll tell in a bit the details on that case, which is pretty interesting. On the blue bar curve graphic, you can see the current COVID hospitalizations and the trend throughout the month. So you can see that it's not quite a flat line, but it's has a trend towards decreasing, which I guess is pretty good for you know, for the infections at the state level. And then I think it's an interesting graph when you see it on the right hand side on the red line. It's the trends of ED visits with COVID-like illnesses compared to previous seasons. So you can see the peaks in March and April, and now, at least in my state, you can see a downtrending of the number of cases. At least at May 16, yesterday, things were going down appropriately. So this was taken from the NCD-HHS COVID task force from North Carolina, so it's pretty updated. So as you can see, the trend in my state has been, you know, relatively good. We haven't had any issues with the system or the PPEs and things like that. So basically, since this whole thing started in mid-March and moving forward, we were using a lot of information from societies around the world. We used some of the experience from Europe, from Italy, and Spain initially, also paying attention a lot of the Asian experience. But our society came up with this visual abstract in which we, you know, we pretty much follow all these measures, like the personal protection. In Duke, we have a standardized protocols to recycle some of the masks and PPE. In terms of service rationalization, you can see that postponing all elective cases was the norm at the beginning. Now we are doing elective cases and we're moving forward towards more complicated stuff, and I will show that in the next slides. We are almost 100% doing virtual meetings and virtual clinics as well. In terms of laparoscopy, at the beginning we had some restrictions because of the you know, the concern of the transmission of the aerosol from the pneumoperitoneum. But with more information that we have, we know that it's valid and it helps with the proven benefits of reduced length of stay. We also have a set filters for smoke evacuation, and we're minimizing the use of energy devices. One thing that I found particularly interesting was the ports that we were using. At the beginning of the pandemic, we were using step ports that include a sheath that is introduced with a Verus needle type device with a sheath, and then you introduce the trocar, but that communicates and kind of extend the abdominal wall, letting the pneumoperitoneum come out. So we moved to other type of technology in terms of ports. We're almost always testing all our patients before they go to the OR 72 hours prior, and if there's an emergency, we'll do the rapid testing. We can do it below an hour, and we do have dedicated COVID ORs. So it all started in April 30th that we were doing cases. We combined all our services from bariatric to acute care surgery and surgical oncology in one. And initially we have limited laparoscopy. Moving forward to May 4th, we started doing more selective cases, elective as well. And laparoscopy was, you know, more and more used throughout the system. However, in terms of OR utilization, we were partially open, and we were sharing blocks with all surgical platforms. And at May 4th, we decided to open. It was previous to May 4th, we were only doing cases in the hospital, and we closed all our ambulatory centers. But at May 4th, we're moving most of those simple cases from general surgery to the ambulatory centers, so we can leave the more complex to the hospital. On May 18th, and this moving forward, this is what is our strategy at Duke. On May 18th, we have more elective cases. Essentially, we can do all those cases that were rescheduled prior to this whole pandemic and the lockdown. And for the first time, we're going to be able to do bariatrics. However, we're not going to have full access to the OR, and we're still on shared blocks. So every service share their blocks, and we just have to put the cases that we know need and share it with all the partners and providers. We are not recommending changing the strategy in any of the cases, but we're limiting the cases to only primary cases. So we're not doing revisions at the moment. And we have discussions in terms of if you want to do duodenal switches and stuff like that, there are cases that take long. The strategy, so moving forward, we're going to have a hard stop on June 1st, where we continue to do elective cases, including bariatrics. And the goal is to be at capacity in terms of OR utilization, but we're not sure what's going to happen. That's our goal. And the overall is to move forward in June 15 to go back to our usual block allocation. So seems like by mid-June, we're going to go back to, this new normality. Granted, we're going to still be testing patients before all the cases. What are the challenges that have been that we've seen in this period of transition to normal? So the challenges is that we currently have shared block time, so you cannot do all the cases that you have in the backlog. Pre-op testing is sometimes a problem because we have to contact the patients, test them 72 hours. In my hospital, we take care of patients traveling from other states, so it makes it a little bit of a challenge to accept testing from other institutions and other labs, but we follow the protocol similar to what Dr. Santos said earlier in terms of questionnaires beforehand. Also, the clinics are not at full capacity. We have a diminished volume due to social distancing and restrictions, but we are still doing virtual visits. There's a significant amount of surgeries that were rescheduled, and those are the priority now, but we still have to keep going with all those general surgery cases that need attention now, especially gallbladders and hernia. As I said earlier, we're not doing revisions for now, but hopefully after June 15, we'll be able to start working on that. We have some challenges with our pre-op workup, at least in my field, bariatrics. We rely heavily on endoscopy, and that is a bit of a problem in order to get patients for a pre-op workup. And also what I found is patient fear. We call and contact all these patients to get them to the OR, but unfortunately, a big percentage of patients are still afraid to come to the hospital. They're feared of getting infected, despite all the measures that we're doing. With that, I would like to stop and again thank the opportunity, and happy to take any questions.
Yeah, thanks Dan for a very nice presentation. And have you started with robotics there in your center at Duke?
Yes, so we consider that part of laparoscopy, and some cases have been done there. Basically hernia and some colorectal work. No robotics in bariatrics yet, but next week, on the week of the 28th, I'll have the robotic room, and I'm just going to try to do some cases. It's a bypass, and I have 2 bypass, and then the duodenal switches, I think that we have to discuss with the hospital leadership, because they still review the cases, on a daily basis, and the division chief and chair are rather involved in selecting the cases and approving those that can move. But I think in June 1st, those restrictions are going to be lifted, and then by June 15, if everything goes well, we'll go back to our regular blocks and regular scheduling.
All right, wonderful. So I'll just launch the 3rd poll, and then we move to Dr. Rodriguez for a perspective about Cleveland Clinic, Ohio. So this is the question which I would like the attendees to answer, please. Do you think minimally invasive surgery pose more risk to surgeon than open surgery? So first answer is yes, MIS carries more risk to surgeon. Second is no, MIS carries less risk than open surgery. We are talking about transmission of the COVID-19 disease. Third option is both carry equal risk, and fourth option is I'm not sure. So it is kind of a tricky question, not a lot of evidence there, a lot of opinions around. So let us see what our audience feel about MIS. And I would also request everyone who is writing questions in the chat box to please write it in the Q&A section, so the panelists can answer the respective questions there itself, and then we will take up all the questions at the end after the presentations are over. So I'm stopping the poll now. We've got 55 votes, and you can see the result. All right, so 33% believe that both carry equal risk, and 24% believe that MIS carries less risk. 31% believe they carry more risk. So kind of equally divided opinion, and it would be interesting to see how our speakers feel about it. But yes, a lot of people are not sure as well. So can I ask Dr. Rodriguez from Cleveland Clinic, Ohio, to kindly present his perspective about what are they doing? He's the director of surgical endoscopy, and it will be it is a different state than North Carolina, so they'll have different statistics and some different institutional policies. Dr. Rodriguez, please.
Yeah. Well, thank you, everybody. And again, it's an honor and a pleasure being here. Vivek, thank you for the invitation. And thank you, Raquel, and thank you, Dan, for your great presentations, because you already laid the land for all of us. So just in the interest of time and not being redundant, I'm going to skip doing my PowerPoint because it's very similar to Dan. So Ohio, similar to North Carolina, was one of the states where early measures were taken. So we were asked to stop elective practice the first week of March. And what the state did is that they allowed surgery to continue under 4 different categories. And the 4 different categories that they did was if it was a life-threatening condition, if there was any risk of permanent dysfunction of an extremity of an organ system, for oncologic cases, so if there was any risk of metastases or progression of disease, then there was an indication to go. And the last one was really rapidly worsening to severe symptoms if surgery was to be delayed. So really there was a bit of a strict, definition for surgeries that were able to continue. And 2 weeks ago, they added one, which was if patients had severe symptoms that would cause an inability to perform activities of daily living, then surgery would continue. So that really gave us a little bit of a more kind of flexible view into what we considered something essential. So last Monday is when we started doing surgery with a little bit more of a routine, still within certain limitations. So just to backpedal a little bit, we've tested at our hospital over 40,000 patients for COVID, and about 10% of those have been positive. So again, the statistics in Ohio are very similar to North Carolina. We've only had about 23,000 COVID cases in the state. So we really were able to flatten the curve early on. We never looked at MIS as a different category within surgery. We never put additional restrictions into minimally invasive surgery. So a lot of the services that we're operating, whether it was during acute care surgery, for common operations, gallbladder, appendix, things like that, we were all doing laparoscopy. Personally, I was doing a lot of revisional surgery, both bariatrics and foregut throughout the pandemic in patients that had, again, severe disease, mostly risk of malnutrition. And we never moved away from doing robotics or laparoscopy. I think what changed when we started doing routine testing like everybody else a couple of weeks ago is that the measures for personal protection were a little bit higher. So before doing routine COVID testing, we were operating in laparoscopic cases with N95 masks as well as for endoscopy. And since we started doing routine COVID testing, then we moved away to just kind of, standard personal protective equipment and using face shields. But we're trying to save and be conscious about our personal protective equipment, for the cases that we really need. We haven't seen a big surge in patients kind of flocking through our doors to do surgery. I think the reality of the COVID care is pretty dramatic. In the United States, about 4 to 6 million people every week have filed for unemployment. Many people have lost health insurance. So I think it's going to take a few months, if not maybe at least a few years, for things to go back to what normal was before COVID. But from a surgical perspective, we started doing bariatric operations this past week. And every service is kind of slowly revamping what they consider is part of their essential operations, again, within those limitations. I think the big fears that remain and why we're kind of closely following our cases is obviously the lack of PPE. And the second thing is, everybody's concerned as a lot of the social distancing measures relax, that there may be a second peak and it may throw a lot of the hospital systems into, a COVID intensive population. So, we've always kept isolated units since we started planning mid-February. So we had an isolated ICU for COVID patients. We had isolated floors for COVID patients. We built a temporary hospital at our medical school to avoid, overflowing our hospital. And luckily here in Ohio, I think cases were really well controlled. So we never had to use all of the resources that we had focused towards COVID. But I think it's important that we follow closely what things look like, especially as the social distancing measures relax here in the United States.
Thank you, John, for a wonderful perspective. And it's very reassuring to know that you have been doing bariatrics because most people in India have stopped it. And if you have been doing it through pandemic and even now you are continuing it, it's a nice thing to know about. And you have not seen any major complications. This is what I could understand.
No, we haven't. And again, all these patients are being tested routinely. And I think there's a lot of ethical perspectives in this. And one of the things that we have to realize is that in the United States, patients have to go through a different process that is mainly dictated by insurance. So a lot of our patients here who are state insured have typically, 6-month diet requirements, and they ask for consecutive appointments. So a lot of the patients that were at the end of that 6-month diet requirement who got approval for bariatric surgery, that approval has an expiration date. So for a lot of those patients, if we didn't do their operation within their expiration date, that means that they have to restart the process and potentially face, all the limitations of having to go through 6 additional months of bariatric evaluation. So I think there's a lot of ethical dilemmas in this process, and unfortunately, I don't think that every player in this pandemic has been on the same side of the team. So, we've seen some insurance companies relax a little bit their restrictions, and that has helped us do a lot of things, like, for example, virtual visits, which were typically not covered by insurance, I think, in most of the United States. Now we're negotiating because we moved pretty much to 100% virtual visits in our practices. So we haven't been physically seeing patients unless it's for some specific point, like, removing staples, removing stitches, drains, wound evaluations, things like that. But, I would say that at least in our service, about 99% of the new patient visits have all been done virtually. And a lot of our bariatric evaluation has been done virtually. And I think potentially that's going to be one of the positive impacts that this is going to have, is that we've learned and we've realized that for a lot of our patients, it's very convenient and cost effective to have virtual evaluations and avoid, visiting the hospitals, spending a lot of time in waiting rooms, wasting a significant amount of time. So hopefully that'll be one of the positive impacts that this is going to have long term for our practices.
All right, thanks, John. So moving out of US, we can have some perspective from Middle East by Dr. Ricard Corcelles from Cleveland Clinic, Abu Dhabi. He is a professor of clinical surgery. and it would be good to know what is happening nearer to our country. Dr. Corcelles, please.
Hi. First of all, again, thank you for the invitation. Thanks, Vivek and the CRSA Society. I hope you have my slides on screen.
Yeah, we can see them very well.
Perfect. So I don't have to add that much. Basically, I think that my previous colleagues and partners, Raquel, Dan, and John, have made a fantastic overview about the situation. I just want to add some specific details about what's happening here in Abu Dhabi and in the UAE, generally speaking. I have no disclosures for this talk. It's been almost or more than 2 months since the WHO declared COVID-19 as a pandemic, and worldwide, this is data from last Friday, we have almost 300,000 deaths. But what's the situation in the UAE, in the country which I'm working nowadays? So we have more than 20,000 confirmed cases and at around 200 deaths. If you can see the screen, this is data from the DOH, the Department of Health of Abu Dhabi. You can see the image, the chart. On green, you can see that's the trend of active cases on the Saudi Arabia. On violet color is Qatar. And in the third place in this navy blue color is the UAE. So we are on the third position in the GCC countries of active COVID cases. We are nowadays experiencing probably what's the peak in our country. But the problem maybe is that here at the GCC countries, the apex is not reached in most of the countries. No, that's why here at Cleveland Clinic Abu Dhabi, we started a long time ago to we started to design facts for contingency, you know, and basically to protect our staff and our resources. I'm just going to skip quite fast some of my slides, but basically I think that that's one of the most important of them is we almost canceled all elective cases and endoscopic cases. Only at around 10% of elective cases have been still going on. And it's important logistically to define what sort of operation we have to do during this pandemic. So we have to clearly identify which are the emergency cases. And I don't know if you can see this small square here. So we decided to categorize tier 1, all these elective cases, tier 2A, all urgent cases that can be delayed for more than 30 days. Here to be those cases that need to be done in less than 1 month, and tier 3 are those emergency cases. No, so it has to be a clear concept about how to triage patients, and maybe during this period of time there is a room for some alternative treatments, especially in cancer. No, and one of our speakers is going to talk, I think, later on about cancer during this pandemic. Also, we have to consider maybe some non-operative management in several pathologies such as appendicitis or cholecystitis, for example. But at the end, our endpoint should be or must be to protect our patients and staff. The advantages of teleworking has been mentioned before, and the use of all the online resources has to be expanded, cancel all non-essential activities such as M&Ms, MDTs, etc. Practical guidelines during this pandemic, to be frankly speaking, there are only few studies that are being performed about the viral transmission during surgery, especially during MIS, which is our focus of interest here. And there is no consensus about the risk, and we can discuss this later on. But aerosolization is, of course, the main concern situation that we can face. But how we do surgery safely at Cleveland Clinic Abu Dhabi? First of all, we test all the patients, and maybe it is important to specifically ask them to sign a specific written consent. We had to take all the airway management precautions and use negative pressure rooms. Importantly, and I think that no one has mentioned, that only essentially staff has to be doing those cases. And we can talk later on about how it is impacting to our fellows and our residents and all training programs, generally speaking. As PPE, we use all those PPEs recommended by the WHO and CDC. Importantly, minimize electrocautery. Some studies have pointed out that in between the different systems of electrocautery, ultrasonic is probably the one that we mostly have to avoid. And of course, cleaning of equipment in specific systems. No. I'm not going to stand that much on laparoscopic ports and practical actions. I think that most of them are known for all the audience, and we can just skip this slide. But at the end, the way that we can do surgery safely in COVID positive patients is practice, practice, and practice. I think that the practice is the key. So we should be treating all patients during this period of time after they were COVID positive, and do all these preventive strategies and maneuvers routinely, even in COVID negative patients. The advantages of telehealth, again, have been mentioned before. Questions still arise about if it's safe enough for a patient, about it's properly used in new consultations. And talking about that, just let me mention these studies. This is a randomized controlled trial done in Barcelona, comparing conventional versus telemedicine in a general surgery department outpatient clinic. There was no difference in between both systems on clinical outcomes and patient satisfaction. So it looks like it's helpful, and as John said before, is here to stay, and that can be efficiently implemented in different healthcare systems around the world. Just to finish my presentation, I'm going to give you some data about Cleveland Clinic Abu Dhabi clinical care area. We know that generally speaking, 5% of COVID-19 patients will require ICU level of care admission. We at Cleveland Clinic Abu Dhabi, we increased our ICU beds capacity from 72 beds to 100 beds. Among those, 66 are fully dedicated to COVID-19 patients. And as we are now on the peak of the pandemic here in the UAE, we aim to expand these 82 COVID-19 beds, these 66 beds to 82 beds. Just to give you some numbers, since March, a total of 167 ICU patients have been admitted for COVID-19. We had 125 patients with severe pneumonia and ARDS. 30 of those patients presented with a stroke. 5 of them required ECMO. Importantly, and we are proud to say that 35 were extubated from mechanical ventilation, and a total of 131 discharged from the ICU. As of today, we are almost 60 patients in the 3 ICUs at CCAD, out of which 37 on mechanical ventilation. We are keeping 8 of our patients on prone and 5 on ECMO. Unfortunately, to date, we reported 13 deaths in the ICU, 7 of which were related to COVID. And that represents around a 4% ICU mortality rate, which is in the range of mortality that it's been published around the globe. Just to summarize my take-home messages, I think that it's clear that there is no scientific evidence to support the use of open versus lab versus robotic surgery, and that can answer your first question during our webinar. However, we have to respect the theoretical risk of transmission from the abdomen of infected individuals. The way to decrease possible risks is to follow all recommendations. As Dr. Guerron said before, we also follow strictly SAGE's recommendations, which I think that are pretty clear. For the challenges can be what's going to be the role of those physicians that are redeployed from their normal area of expertise. When is the time to restart normal surgery? As we have mentioned before, telemedicine is here and it's going to stay for a long time and be implemented worldwide. Unfortunately, this pandemic will impact our residents and fellowship training programs. And with that, I will conclude my presentation. Thank you so much. And again, I appreciate this kind invitation.
Thanks, Dr. Corcelles, for a different perspective about what is happening in Abu Dhabi as compared to other places. I think a lot of it depends on the local situations. A lot of it depends on the numbers around you, the severity of the disease and the institutional protocols, as well as how the government is kind of looking at this pandemic. So new things, many people are asking many questions. So I would ask Dr. Surender Dabas to kindly explain what he has been doing. He's a very good friend and he's a surgical oncologist, a dynamic surgeon, huge practice. He has done a lot of cases during this pandemic. So after Dr. Dabas is said, then we'll have other founding members of CRSA India, Dr. Saklani, Dr. Jagdishwar Gaur, Dr. Amit Gupta, who can also ask questions, as well as we have many questions already. So if the panelists feel they can answer some of these questions in the Q&A boxes, there are many questions relating to filters and other stuff. Dr. Dabas, can you...
Hi Vivek, can I share the screen?
Yes, sir, please.
Can we see the screen?
No, we cannot see the screen. Did you share it?
I'm just trying. Just 2 minutes.
Meanwhile, I would ask...
Vivek, I have to rejoin to please share just give me 2 minutes.
Yeah, please take your time. We'll answer some questions by then. I would ask Dr. Dan Guerron about what filter or smoke evacuation one should use, or which one are you using? Are you using any special filters?
Well, so we have two companies that are currently using is the Striker platform, that it's similar to the the big smoke evacuators that we have, and it goes directly from a port to a generator and then to the smoke evacuator. And then we recently had we're testing one of a Medtronic platform that can be combined with the laparoscopic platform and the diathermy pencil. So those are the two companies or equipments that we're using at the moment. Most of them, I think they work well. Some of the Striker equipment has the particular detail that you can actually tell the machine to disufflate for you, as opposed to constantly circulating the smoke. Whereas the Medtronic one is it only suctions when you want, especially when you're doing the pencil. At the beginning of the pandemic, they were a little bit concerned of this aerosolation, and I think that we, as Dr. Corcelles said, it's a matter of training. It's not easy to use and get accustomed to all these new filters, but the key here is to constantly be doing and getting a lot of repetitions under your belt in order to master all this equipment. It's not easy. At least in my hands, it was a trial and error to do the desufflation feature from the Stryker device. But now I think we got it done. It's not just us. You need to, you know, coordinate the circulators and ORTEX and all that.
Yeah, I think a lot of companies, almost all of them, Stryker, Stolz, ConMed, Medtronic, have smoke evacuation filters with ULPS, ultra low particle size, and they can filter these viruses. But as mentioned earlier, there's no real evidence about this virus spreading through this aerosol. Doctor,
I mean, one of the things I just want to add, more than constantly evacuating, you know, the smoke and all that, it's more concerning when you extract the specimens or when you introduce instruments and there's leakage and stuff like that. So I don't think we can 100% control the smoke evacuation, but again, I think practicing and training is key.
Yes, I'm agreeing with Dr. Dan. I think that practicing, and I think that those small details like doing quite small incisions, secure the ports, use those ports that some of them that they have balloon tips or the threading versus the suture that can avoid the movement of the ports that will help. Also, try to minimize all the instruments change. And another point is probably to work at the minimal pneumoperitoneum pressure as it's possible. In addition to that, probably ideally use a negative pressure ORs. That will be also very helpful.
I would like to add something. I think if you test the patient, if you made a preoperative screening with clinical and epidemiological features, you perform the PCR and maybe to add a serological test, you will have 98% of reliability that the patient is not COVID positive. So adding to that, you have to go to the operating room, considering that you have this 2% of risk of having COVID positive patients. So you have to wear a proper mask. It's better to wear FFP2, even you are really careful with the filters and really careful with the changes of instruments. And you have to protect your eyes also with glasses or face shield. So it's like you have a low risk, but you have to be really cautious with your personal protection as the protection of your team.
yeah, and I think Dr. Avni Saklani had some question. Dr. Saklani, can you please ask the panelists?
Yeah.
Dr. Dabas, I can see Dr. Dabas now.
Yeah, Vivek, actually the mortality for elective surgeries in multicentric studies was 19%. I'm not sure if you combine all the panelists, did they have such excess mortality in elective surgeries that they did? Can you hear me?
I think there were some papers saying high mortality. There was one paper from China which said 20% mortality after COVID-19. Has anyone seen it? I don't see. All the presenters never said that they saw this kind of a mortality in their practice.
So I can say that in these 2 months, in March and April, we have carried on 440 surgeries. The patients were tested, and we stopped some of the patients before carrying the surgery because there was some suspicion of being positive. Some of them were really positive, but we delayed the surgery. And in these 440 surgeries that we performed, the outcome was the same as before. So I think that the risk is when the patient is COVID positive. So you have to avoid that. You have to avoid to go with to the operating room with the patient with any suspicious of being positive.
I think Dr. Dabas is connected. So Dr. Dabas, can you share your screen?
Yeah, I'm just sharing my screen now.
Yeah, we can see it very well.
The screen. Yeah. Good evening, everyone. And there are a lot of surgical oncologists from India just sitting on Zoom right now. And the scenario is different for us and for elective surgery. I can say the oncology surgery are not elective surgery, they're basically semi-emergency. Because we have some timed surgery, like in CA esophagus, we give chemoradiation first, then we have operate. So then there's a time after 6 weeks of completion of chemoradiation, we have to operate. If we delay it, then there's a lot of problem during surgery. So we have some timed surgery, so we have to go for surgery. So the lockdown in India was started in end of March, I can say that. And till now, we have more than 90,000 cases in India, and there are few centers which are becoming high volume COVID centers, like we can say Mumbai, Delhi, Hyderabad, Bangalore, and Ahmedabad. And these are the centers where oncology practice is more prevalent. So, and we were in dilemma, should we go for surgery or should we stop doing these surgeries? But like in oncology, we cannot wait for a long time and we don't know when it is going to stop. COVID is going to stay and we have to be active basically. So what was our policy for doing surgery during this COVID time? We were doing open surgery plus minimal invasive surgery both. So till April, we were not doing any COVID tests for all the patients. So this is a scary time for us. Should we operate or not? But at that time, we will sending all our patients to flu corner and then sending the patients from flu corner to the respiratory medicine department, where we get a clearance from the respiratory physicians. Can we operate or not? Just based on the finding of the chest X-ray and the symptoms. But from since 1st of April, we were doing COVID tests to all of the patients whom we were operating. So the volume was down in the last part of March, but from 1st of April, the volume again picked up and we are doing regular surgery since 1st of April till now. The only evidence what we have till today that we can do MIS during this time is we have around 50 members in my team and till now we are all COVID negative. We are doing surgery since last 1.5 months and we are doing regular, I can say robotic surgery, not laparoscopic surgery because we are not doing laparoscopic surgery much. We are doing robotic surgery a lot. So what are the things which we are following? So for everyone, we are doing our health screening for all my patients, plus my health professionals, my ward boys, my staff nurses, my OT technicians. So we are doing COVID tests for all of them in all 15 days so that nobody is getting COVID positive and we can just screen our health professionals. So COVID-19 status is mandatory for all of the patients before admission. Then we keep our patients in isolation. Means we are not keeping them in general ward like 6 patients in one room. We are keeping our patients maximum in double rooms, single rooms. And then all medical professionals should take precautionary measures like N95 and PPE, mainly in the wards also and mainly in the OT also. So now the selection of patient is very much when you are planning our surgery, we are doing regular surgery. We have to just select the patients who require surgery right now. So we do COVID tests for before the surgery also. And the time interval, you ask me, we are just, if the COVID test is negative today, we just take it as COVID negative for last 48 to 72 hours. If some patient cross the time, we redo the test for these patients again. We try to give neoadjuvant therapy if we can give, like in CA lung. We are not operating lungs. We are not doing lung surgery till now since last 1.5 months. But like for lung, we try to send these patients for neoadjuvant chemotherapy and then we can operate later on. But there are few patients who don't require even post-op chemotherapy, like early colon cancers, early stomach cancers, early pancreatic cancers, early endometrial cancers. These are the patients who require surgery on an urgent basis. So these are the patients who are undergoing, we say robotic surgery. And we try to defer the patients like early kidney cancers may wait, early prostate cancer can wait. The kidney cancer and the bladder cancers with bleeding, we have to operate. We have no other options. So after selecting the patients, we have to go for surgery for these patients. And we take a minimum precautions in our operating room. We try to keep the staff at the minimum. And we try to keep one person, like one nurse, one OT technicians, one assistant, one surgeon, and one anesthetist. And we don't allow any change of the staffs in between the cases. one staff will be there for the whole case. Intermission is done basically in a separate room, it's a negative pressure room. And then we shift the patient in the OR and with the minimum staff. And the surgery should be performed by the most experienced surgeon. Right now, we are not taking any teaching classes. We are not just doing surgery with the junior ones. We are doing all the surgery has been done by the experienced persons. And what more precaution during surgery? The port site should be small. There should be no port site leaks. The most important point which is coming in MIS is aerosol disposal system. So like we have air seal, we have HEPA filters, but we in India don't have HEPA filters and alpha filters. We basically are managing with air seals, and we have double suction in the air seal so that there is no disposal of the aerosols outside this, and we have a closed circuit basically. And we try to keep the pressure less than 8 millimeters of mercury. And again, we have an advantage in robot. And basically the XI system, we have the ABBY system of cautery. And we try to keep the electrocautery state minimum so there is no aerosol generation during the surgery. We are avoiding any harmonic scalpel during the surgery. Bipolar forceps are preferred one. And we should not suddenly desufflate. It should be avoided basically because the aerosol generation is more during that time. And if you can avoid surgical drains, like when you do a robotic esophageectomy, sometimes we used to put a drain in the abdomen, but right now we are not putting it. So these are the precautions which we are taking every day during our surgery. And hopefully, God grace, we are safe till now. But these universal precautions are very must when you are planning your surgery during this corona time. Because this is going to stay for a long time. And we have to stay healthy. Our health professionals have to stay healthy. We have to take precautions. So this is what we are taking at our center. Dr. Jagdish and Avinash Saklani, they are the very prominent oncologists. They must be taking the same things. And they're doing the surgery, I think, since the beginning. But there's no other options for us. We have to go for surgery during this time also. And maybe by this, tomorrow onwards, the volume will increase because we are just coming out of the lockdown in our country. Thank you, everyone.
Thank you, Dr. Dabas, for that presentation. I know you have been doing a lot of surgeries, and I think that's a good motivation for everyone to restart. Dr. Jagdishwar Gaur, what are your comments or any questions you want to ask? Can you unmute yourself, please?
Yeah, thank you, Dr. Vivek, for excellent lecture, excellent meeting. We are also doing some cases, but I feel our Telangana government doesn't allow COVID tests. So it's been a very huge risk for us, and we are highly selective in doing cases. And majority, 70% are open and only 30% are robotic as of now. So one of the speaker was telling laparoscopy doesn't have any risk during COVID test. Can I get a clarification on that?
I think a lot of speakers believe that MIS and open surgery have no different risk of transmission to surgeon. Dr. Rodriguez, can you come on that? What do you think?
There's been a lot of kind of word of caution about laparoscopy, and I know that there's been reports that for the most part are not very well founded by data. So I don't think that there's been any major research study that has looked at a higher risk of COVID infection with laparoscopy. I know we worry about aerosolization and things like that, and I think we've discussed some of the measures that we're all taking to avoid that and protect personnel. But the reality is that there's nothing that shows that the risk is higher. I was a little bit curious from Dr. Dabas' presentation about avoiding use of the ultrasonic dissectors. I assume that that's because of the smoke generation, or has anybody else been using that as part of their policy? Raquel, how about you guys in Spain, since you had probably the COVID experts really compared to all of us?
Well, we are using the same devices as before. We didn't change. There is a concern about the harmonic devices because of the smoke, but I think that the smoke in the laparoscopic surgery is inside of the abdomen till the moment that you evacuate the gas, mostly. Some can, there must be some gas leak in the port sites or when you change instruments. But as I say before, there is now a study who find RNA of the virus in the peritoneal fluid. There is also findings of RNA of coronavirus in the stool or even in the blood, but any of these studies couldn't demonstrate that this RNA could grow in the culture after they found. So it's not clear that it will be contagious. And there is also no evidence of surgeons that have been infected after laparoscopic surgery. So I think that there is a lot of fear, but we have no data to demonstrate that there is more risk.
Yeah, so I think, sorry, I think one point that has been made multiple times that is important as we try to protect ourselves, and especially for, you know, all of those that are working in academic institutions where you tend to have, you know, more than just a basic personnel for a case. You know, you always have, you know, students, residents, nursing students, all kinds of people that typically participate in a case, whether it's from anesthesia, nursing, or the surgical team, is to really minimize the exposure. So one of the policies that I didn't mention that we have is that during intubation of a patient, typically everybody except the anesthesia team leaves the room. So measures like that, you know, we're minimizing the amount of people that scrub. So, you know, we have a fellowship and a residency program for our specialty. So basically, you know, if there's one fellow, we only allow one resident, only when it's needed, you know, for not just education, but also for assisting with the case to really participate. And we took all of our medical students outside of any clinical exposure.
Good point, John. Dr. Amit Gupta is here from AIMS, Rishikesh. It's a large teaching institution. Dr. Amit, do you have any comments or any questions to ask?
Can you hear me, Vivek?
Yeah, we can hear you.
Yeah, Vivek, I think recently there was a paper from Italy and it has been published in the Annals of Surgery, which clearly indicates that the peritoneal fluid of the patient who are infected with COVID-19 is highly infectious. And the paper clearly warns that Italians learned this lesson very late. And by the time they realized, it was too late. And many surgical staff, many nurses and anesthesia people, they got infected, and they did a study, and the strain of the virus were in great concentration on the surgical gloves and on the gowns of the surgeons. So I feel that one of the speakers mentioned that there is presently no data available, which suggests that peritoneal fluid can be, have some potential for contagious.
I think that paper was mentioned by Dr. Santos, that there is this paper where peritoneal fluid.
I feel that whether we are doing open surgery or doing laparoscopy or doing robotic, I think one should keep this in mind. And
absolutely. So I think a lot of us have read that paper.
That we must do COVID-19 testing beforehand, without fail.
Yeah. And I think in our poll also, if I would recollect, most of the people were doing COVID tests. So 78% of the attendees were doing COVID tests before any surgical procedure. So yes, absolutely well taken, Dr. Gupta.
I want to make a comment about ultrasonic. I think that, and it's in relation of what John said before. I think that all the controversy of ultrasonic comes from a paper, which is a quite old paper from 2006, in which the paper was evaluating the expected debris from different energy devices. So, and what the authors saw is that the ultrasonic, the plume was higher in relation to the electrocautery or laser ablation device. So that is why it comes this controversy about using or not ultrasonic. I think that I can remember that electrocautery. I think that it was releasing verticals who were 0.1 microns, laser ablation it was 0.3, and I think that the highest was with the ultrasonic. That is why some of the guidelines recommend not to use ultrasonic. Having said that, I agree with Raquel that I believe that nowadays there is not substantial evidence that can support not using this energy device. But I think that all the controversy comes from that manuscript.
You know, I think another comment in research that we have to be very careful with is that COVID is really rising this wave of, you know, publications that are coming out in every single specialty. And, you know, I've been asked to review a few papers for COVID, and I was talking to one of my friends who's actually a pediatrician, and in her field, they just started a new journal club citing the most ridiculous papers coming out of COVID. So I think we have to be very careful with everything that's going to be coming out in the next few months in terms of publications, because every single hospital system is trying to, you know, get in the forefront of publications for COVID. And I think the data is somewhat questionable in terms of what we're going to be generating. And there's a lot of potential for things coming out that are going to be hurting our practices in our field. So I would just be very cautious with everything that's going to be coming out COVID related, I think, in the near future.
Yeah. We have Dr. Bhupendra Yadav from Intuitive, and Intuitive has supported this webinar as well. Dr. Yadav, do you have any comments from industry perspective, what Intuitive thinks, or, you know, how does it look at this pandemic, and when do you think it's going to get over from an industry standpoint?
Yeah, thank you, Dr. Bindal, and thank you all the panelists. I think we are as concerned and as cautious as everybody else. And the primary focus from our side, our internal medical affairs team keeps us updated about all the publications. And the focus is to assist our surgeons, the patients, to the best of the capabilities. And we keep following the same protocols, what are coming out of society guidelines. So there's no specific protocol, as you know, Intuitive. It's not kind of in clinical recommendations. So we are following the kind of lead from the surgeons and trying to assist in a way that the only thing we are doing on the back end is keep checking the systems and robotic operating systems remotely or in person, so that surgeons who are operating or who wants to restart, they get the technical support they need. Thank you again, all the panelists.
Thank you, Dr. Yadav, for that perspective. I think some questions we have already taken. There are some questions about disinfection of OR. Any guidelines from the panel by Dr. Jagannath Dikshit? So, Dr. Ricard Corcelles, can you just answer how can you disinfect the OR, or how do you disinfect the OR in between the cases?
Yes, sure. So we basically we designated 2 COVID positive ORs in our 3rd floor, and those are negative pressure ORs. So that's the first thing that we decided to do, is like to define specific ORs for COVID positive patients. But the thing that the process of cleaning surgical equipment, it has to be specifically separated from the rest of instruments used in your OR settings. I mean that those patients that are COVID positive, the process of cleaning of the instruments is absolutely, it comes in an independent way from the standard equipment. So definitely the material used in COVID positive patients goes to a different area rather than the standard material. That's definitely one of the safety checkpoints that it has to be a COVID positive surgical program. Your equipment goes independently from the non-COVID patients.
Absolutely, and I think the second thing which we do is we basically fumigate our operating rooms with silver hydrogen peroxide, and we use it in the concentration of 1000 ppm for a period of 45 minutes. in between the cases. So it's virucidal. It's actually virucidal even at a concentration of 50 ppm. So you can do a silver hydrogen peroxide fumigation for your operating rooms in between the cases. It's pretty quick. And at 50 ppm, it's non-toxic to human beings as well. Okay, so there are two questions for Dr. Dabas. Dr. Dabas, are you here? Dr. Saklani wants to ask you, how did you convince the management to start robotic in these times? And the second question is, how do you disinfect the console in between the cases? So did you have to?
Yeah,
you actually have to convince the management. I think management is always happy if you do any cases.
I'm working in a private sector, so they are more happy to do more cases. We have to convince the patient. This is one of the most important point right now because they are scared of corona. Yeah. So that's why we just take care of everything like pre-op testing, before OT and before admission, and then convince them all of the staff is COVID negative because they're scared about doctors also. The doctor may be positive. So we all do testing in 15 days so that we are negative and we don't infect our patients. And management is the last part we need to convince them. And how we disinfect the console is that just the same thing which we are doing for all the things with this hypochlorite solution. And the console part is basically where my head touches. This is a part of contact with the chopsticks. These are the things we always disinfect after the surgery is over. And we do only one case in one OR, not more than that, in a day. So we have 3 or 4 ORs and we do 3 or 4 cases, not more than that. So we never do a second case at least in robotic OR.
All right, wonderful. And what legal safety do you have if the patient claims he turns out to be positive post-op? So you did a COVID negative test pre-op.
We are taking consent from everyone before admission. You might get infected in hospital, not from us also, because another patients also. Maybe the staff also, maybe the dietary people, maybe the nurses, maybe the ward boys. So before taking them in the OT, you have to just sign the consent. You may get infection. If they give the consent, then we just admit them.
I think Dr. Punjani asked this question. He's a very senior surgeon, and actually, we have also been consenting the same. But once the patient turns positive after 7 to 10 days of hospital stay, and he was tested negative at admission, it actually becomes a problem even after the consent has been given.
So what we're doing now, after 2 or 3 days of surgery, we are sending the patients maybe on IV fluids with the nurse or maybe on IV antibiotics. We don't want to keep them for a long time. And we are providing the nurses from the hospital. You go back home, stay at home, because after 2 days, when the things are settled down, they will go home. And we are discharging them early, like nowadays.
So enhanced recovery after surgery in COVID becomes an important thing. Huh? So that's another way to protect the patients as well as the staff. There's one question from Dr. Parimala about the PPE. What level of PPE are you using? Dr. Santos, can you answer this one? What kind of PPE do you use in your practice, in your ORs?
Well, we are using for the standard cases, the elective surgery, when we have tested the patient before, we use FFP2 or N95 mask, covered with a surgical mask above. Then we use glasses or face shields. We use 2 gloves, two sets of gloves, and the rest is the same as usual. But if we are not sure about the COVID status of the patient, then we use complete PPE, covering all the parts of the body, the neck, and with plastic coverings, and then we have also this complete set of PPE if we are willing to use. So for example, in emergency cases where we don't have the opportunity to test the patients, then we use the complete PPE.
I want to add, if I can, one of the things that in surgery, what we do is differently, I think. If the COVID patient is positive, we follow all the protocols that you said, but one of the things that we do in our hospital is if the patient comes from an institution, like a prison. I work in a county hospital too. So if it comes from prison or from a nursing home or some sort of long-term acute care facility, despite the fact that they're negative, they're treated as high risk. So in the OR suite, all the team will wear an N95 and a face shield. But then the same protocols that we use, but that is the only thing that is kind of out of the norm, and the same in the ward. Those patients that come from either prisons or nursing homes, they are labeled as high risk, so they require an extra layer of protection, just like another gown, gloves, and face shield.
Yeah, I'm agree with both of you, Dan and Raquel. I think that if you cannot test the patient, you have to treat him as if the patient is COVID positive, and that is specifically from all the emergency cases. But it's also true that, I've done patients with suspected positive patients, and all the PPE that we use recommended by the CDC makes the case very uncomfortable. You are using 3 pairs of gloves, you are using the N95, and then the shield mask. It becomes foggy. You don't have your these haptic sensation. Your dissection is less accurate. I think that it's not comfortable, and we have to be very cautious when to indicate surgery in a suspected COVID positive. Of course, if it is positive and it's emergency case, you have to do that. But if not, I felt that in one of the cases, I was not comfortable enough to do a fine dissection. I think that we have to be careful on that.
Right. And Dr. Punjani is asking, how do you manage the fogging of face shields or goggles? I think that's a thing everyone is facing.
Painful.
It's a problem. It's a problem whenever you do surgery, and many people are just taking off face shields in frustration. They just can't handle it. Any tips from anyone?
I just tape. So I do the N95, and then I use the mask with the face shield. And then I sneak a little bit of tape here, but at the end of the day, you're taking pieces off your skin.
Yeah.
I think using a tape, so maybe here use a Band-Aid, and then
yeah, I mean whatever anesthesia has, I just get a piece and just cover the edge on my face to create a seal. I agree with Ricard, but what bothers me the most is the temperature and the lack of communication. So you're trying to talk to your assistant, and it's this muffled sound, and it's like, what did you say? And on the smoke evacuator and all that is like basically at the end of the case, your voice is gone, you're sweaty, and all that is very uncomfortable. But if it's emergency, you got to do it.
I think there's a lot of concern about transmission of disease from doctors to patients. So we are testing patients, but the patients are more and more concerned about healthcare workers being infected themselves. And they are asking doctors that, what about your test reports? You're going to operate on us. Or what about your team's test reports? So is there any institution, any panelist who test their healthcare workers every 14 days or every month or something like that?
So I can tell you because I got tested last week, and it's not a very pleasant test. I had the nasal swab. They take a brain biopsy during the whole thing. I think I actually did a colon polypectomy through my nose. But, I think the problem with that, and again, testing is not universally available at an unlimited amount in most places. So here, our testing capacity is about 1,300 tests a day. So our policy for testing healthcare workers is based on symptoms mainly. So, we have a hotline that you call, and there's a triage team that will triage you through symptoms. And if you qualify, and it's basically looking at things like, fever, muscle aches, cough, things like that, then you do get tested. But routinely, we're not doing it. And I'm not aware, except for maybe 2 institutions in the US that did routine testing, and now they're looking at doing antibody testing for their healthcare workers to see if they've, have been exposed and have developed some sort of immunity.
All right. I think that's also important. So what are the Sandeep is asking, what is the personal care that you take before you leave the hospital? Is it just a scrub or a shower? I think a lot of people are doing different things. So you can change into, so what we do is basically we wear a pair of scrubs when we leave home. Then as we get into the hospital, we change into the hospital scrubs. Then we put on whatever PPE is required for our clinical care. Then we come back to the changing room. We get back into the pair of scrubs for our home. And when we get home, we put them for washing and take a shower. So some of us are doing it. So two changes of clothes, while some people are just going to hospitals in their usual dress. But yes, I think a shower before you enter and meet your family is a good option, is a good thing to do. Some other questions as well, but I think in the interest of time, I would just complete this webinar here. It has been 1 hour and 30 minutes, and our panelists have been kind enough to share most of the practices that they have been doing. Any last comments which anyone wants to say from our esteemed panel? So I would like to thank Dr. Santos from Spain, Dr. Corcelles from Cleveland Clinic Abu Dhabi, Dr. Rodriguez from Cleveland Clinic Ohio, Dr. Daniel Guerron from Duke University, Dr. Surender Dabas from BL Kapur Hospital for making it such a lively interaction and sharing their experience, their valuable time with the audience. We had more than 300 people attend this seminar on Zoom as well as labguru.com. We would also thank our CRSA founding members, Dr. Saklani, Dr. Jagdishwar Gaur, Dr. Amit Gupta, and Intuitive as well, Dr. Bhupen Yadav, who supported this webinar. We would invite all the attendees to become a member of our organization, Clinical Robotic Surgery Association. You can go to clinicalrobotics.com and select the Indian chapter membership. You can message me in case any details are required, and we would come up with more relevant seminars in times to come. Thank you so much, everyone, and it has been a pleasure talking to you all.
For organizing such a wonderful webinar. Thank you very much.
Thank you for the invitation.
Thank you.
Pleasure to share the
Thank
panel
you
with
for
you guys.
Have a good day.
It was a
Good evening.
Bye.
Bye.